Talk on a comparative analysis of RP morphological choroidal vascular anomalies in acute and chronic CSCR.
Okay, good afternoon. So, as you said, we're talking about CSR and comparing the different changes in acute and chronic CSR. So, this is a common image which is very easy to look at. You see the spot leak, the SRF, and the fibrin, and you know that this is CSR. There's nothing confusing about that. Let's start with the differentiation between acute and chronic CSR. The time period arbitrarily or in literature is 4 months. But now we know that there are two mechanisms beyond it. That is a pachychoroid and the venous overload. So the venous overload is when there's a vortex vein compression and all the vessels attributing to the posterior pole are thickened. And that translates into a thickened choroid over here, which we're just going to mark off. So what does that happen? So what it means is that because of this venous overload, there's an increased hydrostatic pressure, a back pressure, which causes all these RPE changes to elevate and therefore subsequently what we call blowouts or leaks. But over time, something else happens. There is chronic damage to the inner choroid, thinning of the inner choroid, thinning of the choriocapillaris, which produces signs like the DLS or the double layer sign, where there's a small separation between the Brooks membrane and the RPE. And there it causes RPE damage. So basically, CSR is not about point leaks. It's about a larger area of choroidal damage with a smaller areas of RPE damage with overlying leaks. So the aim of the study is to define what do you mean by a causative RPE lesion. Look at the choroidal lesion right under it and see if there's any correlation. It was a retrospective where we took 30 eyes in each of the groups in which we could possibly do a good EDI study. A quantitative and a correlative analysis was done. In the quantitative analysis, we looked at thickness underneath the fovea and underneath the lesion. We checked the choriocapillary thickness, the large vessel diameters and areas, and also something called the Haller fraction. What was the fraction of the total choroid that was occupied by the large choroidal vessels? So this is how we looked at the choroidal thickness underneath the fovea and underneath the lesion. Again, when you had to look at the choriocapillary thickness, this is how it was measured under the fovea and under the lesion. The type of RPE lesions were divided into three, that is single or multiple PEDs, a PED with or without a DLS, or a DLS without a PED. And the choroidal changes were looked at single large vertical lesions, horizontal lesions, and multiseptate lesions. So this would be a summary of that, where you could see this would be a single PED, multiple PEDs, a DLS, a vertical choroidal lesion occupying more than 80% of the lesion, horizontal lesions, and multiseptate lesions. Coming to the results, the age in both the categories was same. The males, as we expect, predominated in both the arms. But this is what it starts getting interesting when you look at, this is known facts. In acute CSR, the choroidal thickness and the choriocapillary thickness is more in acute CSR than in chronic CSR, which means thinning happens over time. The large choroidal vessels are thicker in acute CSR. The area of the vessels are more in acute CSR. But what is interesting, what we call the Haller fraction is similar. What does it mean? The Haller fraction is the area occupied by the large vessel versus the total choroidal area. The Haller fraction is maintained, which means that when the choroidal vessel or the choroidal vessel, when it becomes thinner, it's usually associated with the thinning of the choroidal stroma also. So the total choroidal thickness also comes down. So that has an indication or possibly an indication about the back pressure effect that is caused by the things. Looking at the qualitative analysis, the most common in acute CSR was the presence of a single PED. In chronic CSR, the presence of multiple PEDs was the most common feature. The choroidal change, the most common choroidal change was a large focal choroidal vessel or a pachy vessel when you had a focal RPE lesion. And again, in multiple, yeah. So basically, the most common was a multiple PEDs in chronic CSR and a focal choroidal enlargement or a pachy vessel in acute CSR. So this is how the correlation went. Whenever there was acute CSR, the most common lesion would be a single PED or a focal PED and associated with a single vascular event underneath it. Well, when you had a larger area of RPE damage, like a double layer sign or multiple PEDs, you had a larger, more horizontal choroidal vascular change underneath it. So just to represent that graphically, this would be a single PED with a large change. When the PEDs become multiple, you had a longer change, and you had larger and longer changes when a larger area of the RPE was involved. So these are some examples. You see a double layer sign, and this would be the area of the choroidal damage. You see a single more larger PED, and the the focal choroidal or vertical choroidal damage is more evident here. Here you see a larger involvement of the RPE, and you see a large septate, a multi-septate choroidal anomaly. Again, a multiple PED here, and you see a larger choroidal abnormality over here. Here you see a single PED happening there with a single larger lesion and a more broader lesion whenever the choroidal or the RPE damage is over a larger area. So all the choroidal indices were thicker in acute than chronic except the Haller fraction, which showed that both the vasculature and the stroma decreased over time. So a quick summary would be the choroids are thicker in all aspects in acute CSC. The acute CSC had a greater occurrence of a single PED and a contributory focal lesion right underneath it. Single PEDs were associated with larger vertical areas. Chronic CSCs were associated with multiple PEDs, and whenever you had a larger RPE damage, the underlying choroidal damage was shorter, broader, and occupied a larger area. And those two are new facts basically. So we're just going to repeat that. Single PED, focal choroidal lesions. And why is it important? The back pressure effect because of the vortex veins could be responsible. The back pressure effect causing a single blowout in a single area with a single choroidal and RPE damage. While in chronic CSR, a larger area is involved, so it is not a back pressure effect. It could be a more expansive deficit of the RPE because of choriocapillary thinning. And that could be responsible for the chronic CSR or SRF changes. So when you want to describe the disease, when you have a venous overload or a block, you have pachychoroid. You have first focal lesions causing focal CSR, focal leakage points. But as the disease gets more widespread, more choroidal damage, more RPE damage, you have more decompensation and more diffuse RPE damage. And that is what this study has brought out. So there are different pathogenic mechanisms due to different thicknesses, different nature of the choroidal vessels, and probably a progression from an acute to a chronic because of lack of release of the pachychoroid disease underneath. So understanding this may help us understand the future of anticipating these changes and treatment of the disease. Thank you.
Thanks, Unni. I have a question. When you're talking about central serous, I could understand both the spectrums what you painted. Now, I'm just going to throw something different at you, and if it's going to be acute central serous, the fluid is coming from the choroid circulation into the subretinal space because of the micro leak which happens because of increase in hydrostatic pressure. When this is not evident in chronic central serous because of its chronic pressure gradient which is being built up, but not enough for the fluid to come into the subretinal space, do you think that it is an over exaggeration or the subretinal fluid, or if I have to use the appropriate words, is the subretinal fluid which is staying for a longer bit of time in its space before it finds its way into the choriocapillaries is a possible hypothesis?
So there is one overlying hypothesis which is being floated now. In acute CSR, there is one anastomosis in the vortex veins between a superior and inferior vortex. That is the whole back pressure. And when the acute spontaneously resolves, somehow this anastomosis gets relieved. In chronic CSR, the anastomosis between two vortex veins remain, but it is not high enough. That is why it doesn't get relieved. It remains in a very background stage, and there is a chronic. So when there is SRF, there is always evidence of a historical leak. Like you said, the fluid might have come inside, but the fluid being resorbed or the RP not being strong enough to reverse the flow of the SRF, or the RP still contributing to a low level of exudation because of reversal polarity. See, the second theory is associated with a lack of glue between the RP and the Brooks. The lack of stickiness that happens because of chronic inner choriocapillary disease. And that is why as a disease gets older, these smaller separations happen rather than acute pop-up of things. And in this entire area where the RP or the choriocapillaries is damaged, there is no reversal of flow immediately. The whole dynamics of the SRF absorption decreases. So, but you cannot just have fluid. You would rather have intraretinal fluid if you have an RP decompensation, not SRF. So SRF has always historically, or at that time, there has to be some area of leak that happened. May not be as explosive or associated with an RP rip as before, but some leak should have happened. Thank you.